So today I'm Dr. Anil Baxi, Professor, Department of Surgery, Index Medical College, Indore. We are talking today about arterial diseases. It comes under section of peripheral vascular disease, and yes, yes. So arterial diseases are many of kind. First, we discuss about the anatomy of the arterial tree in upper limb. So on right side, there is a brachiocephalic trunk which divides into common carotid and subclavian artery, and which continues like a axillary artery. Then that continues under the axillary artery, and after that it's a brachial artery, and then brachial artery divides below elbow into ulnar, radial, and posterior interosseous artery. So those ulnar and radials, they continue in the palm, and they develop a superficial palmar arch and a deep palmar arch, and they from there arises from superficial palmar arch arises digital arteries, and they supply to the digits. So this consists of the arterial structure of the upper limb, and there are a lot of collaterals available around the joint, so as to, if there is any disease or blockage into any of the artery above the joint, then this collateral will try to restore blood circulation and maintain the living of the limb. Now, similarly, arteries of the lower limb. So the arteries of lower limb, mainly the arteries of lower limb start from abdominal aorta. The abdominal aorta at the level of L4, L5 divides into two, that is common iliac. Common iliac again divides near sacroiliac joints into internal iliac and external iliac. The external iliac artery continues under the inguinal ligament as a common femoral artery. Again, the common femoral artery will divide into two. The one is deep femoral artery or profunda femoris, or a superficial femoral artery. The superficial femoral artery continues as a popliteal artery, and the popliteal artery will divide into tibio-peritoneal trunk and posterior tibial artery. Anterior tibial will continue as in the ankle as a dorsalis pedis artery. Again, plantar arch will be created, and that will supply arterial supply to the digits. And this is how it works. The supply of upper limb and lower limb. Now, arterial diseases are many, and they can be divided into acute and chronic, and we will discuss features of acute and features of chronic. The acute illness is when there is the onset is sudden, and the chronic, the disease has been going for many days, many months, many weeks, or many years. So, very important symptom of a chronic arterial insufficiency is intermittent claudication. The intermittent claudication is a type of pain which is crampy in nature, and it is because of accumulation of metabolites and accumulation of metabolites. And because of arterial occlusion, the metabolites are not cleared in time. There is not sufficient inflow of the blood has to clear those used metabolite and for their disposal. The most common site of arterial occlusion is superficial femoral artery, and that's why the calf muscles are the most common site for intermittent claudication. In this respect, we like to tell you about Larish syndrome. The Larish syndrome is aortoiliac blockage, and because of this blockage results into intermittent claudication of thighs and buttocks, and sometimes into impotency. So higher the obstruction, higher the claudication. Now there is a Bayard's classification of intermittent claudication. The grade 1, patient complains of pain after walking. Patient starts walking, and after certain distance, he starts complaining of pain. The pain is never on standing, only on effort or when the muscles start working, the pain will be experienced. And it always comes at a fixed distance, particular distance. And distance at which this develops is called as a claudication distance. So for a given patient, that distance is more or less fixed unless some treatment is initiated or some time has passed and is then instituted some treatment. If the patient continues to walk, even after pain, there is some increased blood flow in the blood, in the muscle, and opening of the collateral metabolites causing pain are washed away and pain subsides. So this is the grade 1. When after walking some distance, the pain comes, and then continue walking, the pain disappears. So that is a grade 1 intermittent claudication. In the grade 2, the pain will still persist on continuing walking, but patient can walk with effort. Patient doesn't have to stop and rest to alleviate the pain. Now, grade 3 is one in which after patient can start walking, patient feels intermittent claudication, but patient can continue walking, and at one stage will come when patient will not be able to walk and he has to sit down and take rest to relieve the pain. That is a great. So there is a difference between different types of intermittent claudication, differential diagnosis of intermittent claudication. In arterial intermittent claudication, the pain will always develop after walking. It is never on standing. When the patient walks, the pain will start. And it resolves also quickly, let's say within 5 minutes, once walking stops, because the arterial blood flow is sufficient during the rest time and is able to wash out the metabolites which are producing pain. In neurogenic claudication, neurogenic pain develops in standing or walking. So even when the pain, when the patient stands up or starts walking, the pain comes quickly. And it disappears after 5 minutes of resting. It takes longer time to disappear. But very important aspect is, at any time, you can feel his pulse being normal and without any ischemic changes on the feet. The pulses will be bounding, there will not be any absent pulses. While in arterial, there will be absent pulses most of the time. And in neurogenic, the pain is because of narrow lumbar canal, that is called spinal canal stenosis. Venous claudication is rare, and it is observed in chronic pelvic venous obstruction as a mechanical high venous pressure usually develops due to deep vein thrombosis, and peripheral pulses again will be normal. Now, because the bulk of the muscles into the upper limb is not much, that's why the claudication is not that common, but can occur during writing or any upper limb exercise. Now, what are the criteria to diagnose intermittent claudication? Intermittent claudication feels like a cramp-like pain, mostly in calf muscles, but it can come into thigh and buttock also, depend on site of the obstruction of the arteries. Now, pain develops only when muscle is exercised, because exercising muscles will require more nutrients, more oxygen, and their metabolites will not be washed away because of reduced blood supply. And the pain will disappear within 5 minutes when exercise stops. Intermittent claudication is due to anaerobic muscle metabolism because sufficient oxygen is not there. So, anaerobic muscle metabolism is initiated, and the lactic acid gets deposited, P substance gets deposited, and that all causes pain. So now superficial femoral artery is the most commonly affected in peripheral vascular disease, and that's why the claudication will be at the calf. So in this accompanying diagram, there are various sites of occlusion are given, and with that related sites for sites of claudication is also depicted. So if aorta is clogged, then buttocks will be affected. Common iliac artery, again, the buttock will be affected because the aorta supplies to common iliac artery only. If common femoral artery is there obstructed or external iliac artery is obstructed, then of course thigh will get the pain, and if superficial femoral artery is occluded, then calf is the most likely to be affected. So the site of pain also provides an indication of site of disease. So if a patient comes to you and says they have a claudication in calf, you know it is going to be superficial femoral artery. And if patient complains of claudication in buttock, then you know the blockage is somewhat higher up, either in aorta or in common iliac. So history itself will point you to the site of disease, and then according to that, you can direct your investigation to confirm the site of the disease. Sometimes there are two blockages. There is one in aorta and one maybe in superficial femoral artery. So in that case, the distal one will come first. The patient will have claudication in the calf. Now, after the stage of claudication, the stage of rest pain comes. The rest pain, has its name depicts, the pain occurs when patient is resting, patient is not walking, patient is not exercising, patient is resting. And this pain is very severe pain. And sometimes the patient feels that while hanging the leg down the bed, he may feel pain to be reduced. But basic thing is the arterial system is not able to supply enough blood to the leg or in that portion, in that particular leg. And the pain is mostly a burning in character, and it's so agonizing that it keeps patient awake throughout the day and throughout the night. It is called crying of the dying nerve. because the nerve supply also comes from the arteries, and if they are not getting sufficient blood supply, they 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 they, they cry, and the cry is manifested in a burning, gnawing type of pain, which bothers patient terribly. And it again signifies that there is a severe decompensated ischemia. And severe pain is followed by ulcerations and gangrene, and that is called as a critical limb ischemia. Even rest pain stage is called critical limb ischemia, because if something is not done, the patient is certainly going to lose his limb. There are certain changes in color, temperature, sensations, and movements of the limb, which will signify whether it's an acute arterial disease or chronic arterial disease. So, when you examine clinically the patient, we have to palpate all the peripheral pulses. All the peripheral pulses means even if the patient has disease in the leg, you have to examine carotids, you have to examine radial, brachial, radial, and of course, you will examine abdominal aorta, femorals, and popliteal, and dorsal pedis posterior. And while you are doing that, you examine it for the aneurysm and bruit. And in case of stenosis, you will get bruit, and in case of collateral circulation, you may get weak pulses below the level of obstruction. So there is a good collateral circulation. Now, once we have established that patient has a arterial insufficiency or arterial ischemia, we direct our investigation to confirm the diagnosis and to find out what best can be done for the patient. So for that, we need general investigation. So general investigation will be in the form of CBC, because if the hemoglobin is low, the oxygen carrying capacity of the blood may be low, and the patient will have rest pain or claudication earlier than what you are supposed to get. Similarly, if cardiac output is low or there is a congestive cardiac failure, if the patient is not able to pump blood properly, then again the ischemia will be felt in more severe condition. So all this will, and if there is the blood sugar raised, the diabetic patient, they get earlier atherosclerosis, they have accelerated atherosclerosis, and the likelihood of them having arterial diseases are much more than the general population. So similarly, other diseases have to be excluded, like serum creatinine is important, because if later on you are going to do any CT angio or inject a dye into this patient, you must know that the serum creatinine is normal, its kidney functions are normal. Because if you give a dye to a patient who is already having renal compromise, it can induce a renal failure in such patients. So one has to be very careful when you inject a dye into renal failure patient. Now, there is a very important investigation called Doppler ultrasound blood flow detection. So what is this? This has the picture shows on the right side. It's a handheld signal detector which works on ultrasound mechanism. And generally, this probe is everyone has seen this probe or this instrument in measurement of obstetric fetal heart sound, but this can be used very effectively into detecting the peripheral pulses. Of course, in peripheral pulses, the probe frequency will be different because the deeper it's a more superficial pulses, so you have to have a higher frequency. So mostly it is 8 to 12 or 8 to 10 uh, frequency of megahertz frequency is used in this Doppler ultrasound blood flow detectors. And it's a very quick one because it can be done in the ward. One doesn't have to go to the ultrasound department, and it can be applied in emergency at any time, and can be done by anyone who has a very little training into this equipment. And the training is very quick. Within 5 minutes, one can learn how to detect this. So, in my opinion, every ward, every acute ward like surgical ward or medical ward and also orthopedic ward, they all should have this equipment handy at, uh, in their for their use at any time. And this is used for assessment of arterial occlusion. And how it works, it is used as a solo to detect the pulses which are not palpable. Of course, if you can palpate with the hand, there is no need for this detector because you have detected it already with your hand. But if suppose it's not palpable, particularly in chronic ischemic cases, then you have to assess how much is the blood pressure into that limb. So you put in this one detector onto the pulse and tie a blood pressure cuff on top. And then you take a blood pressure like you take in the arm, you raise the pressure into the sphygmomanometer, and you wait for disappearance of the signal. Once the signal disappears, you note that point, particular what is the pressure that time, and again you release the pressure of the sphygmomanometer, and then again note the reading into the sphygmomanometer, how much is that reading, and that is the blood pressure into that particular limb. And then you also measure blood pressure into the arm, and then you come out with the ankle brachial pressure index. So generally, normally in lower limb, the pressure is always more, and in brachial artery, the pressure is a little bit less. So the ankle brachial index should always be either 1 or above 1. So if it is below that, that means there is some kind of ischemia there. And there is some blood supply is leaking. It's not in sufficient quantity reaching there. So ankle brachial pressure index is like a systolic ankle BP upon systolic brachial BP. And the normal resting ABPI is generally 0.9 to 1.3. Values below 0.9 indicate some degree of arterial obstruction. And retesting after exercise to the onset of pain can be useful. Drop in the resting ABPI of more than 20% after exercise is indicative of flow limiting arterial disease. So this is the method they have depicted in the diagram. The systolic blood pressure is recorded in brachial artery of the arm, and the ultrasound device or a Doppler detector is put below the cuff distally, and you take the measurement. Similarly, it is done in the ankle to measure pressure onto the post-arterial or dorsal arterial. And each pressure is noted down, and then the ankle pressure index is calculated. Now, once you've done and you have a good idea that there is a definite insufficiency, then we ask for a duplex scanning of the arterial system, in which an ultrasound machine is used and with the images seen onto the screen. Images seen on the screen. And that can show you the stenosis and flow of the blood, and also if there is any ulcerations or stenosis into the arterial wall. Like in this picture, you can see a stenosis as the common carotid bifurcation. Another investigation at our disposal is digital subtraction percutaneous angiography. So it is done by injecting a dye into the arterial system, and the computer takes the images and it takes in images continuously, and then a computer will subtract the other images out of that arterial system and will give us a clear picture of the arterial picture. In this picture, there is a blockage of popliteal artery. Normally, we get a CT angio for arterial system, but sometimes if the kidney functions are not good, then in that case, we may have to get a MR angio. And this MR angio is showing a very tight stenosis into left common iliac artery, and also impending there is some stenosis into right common iliac artery. So once you have diagnosed that there is the arterial occlusive disease, then how do you manage it? So there are general principles to manage it, and which involves correcting the modifiable risk factors. So what are general modifiable risk factors? If the patient is overweight, then you correct, because then the legs will have to carry less weight and they will get tired at a longer distance. If the patient has a congestive cardiac failure, you correct that one. Patient has low hemoglobin, you correct that. If there is a problem of sugar which is not under control, you correct that one. And we encourage patient to do exercise, because during exercises, there will be a lot of stimulus on the muscle to get the blood supply. And over a period of time, more collaterals will develop. No amount of exercise can open the blocked artery, but the exercise will encourage collateral enhancement. More and more collaterals will open up, or those existing collaterals will carry more blood distally. So if that happens, again the purpose is solved, more blood is available into the distal limb, and the claudication and ischemia may resolve. Very important factor in this respect is to quit smoking. If the patient is smoking and if you treat him with anything, it is likely to fail because smoking in his case is a very big factor in which it's a continuous stimulation for arterial occlusive disease. So, in my patients, I always tell them that if you don't quit smoking, there is no point in taking treatment because sooner or later it will all fail. So, if you home that message very strongly, then only the patient is going to make a sincere effort to quit smoking. Otherwise, what will happen? You tell them that you stop smoking, and the patient goes out and lights his first cigarette. And so, uh, uh, what is the overall risk of critical limb ischemia in progressing to amputation is less than 5%, provided the treatment is done sincerely. And the patient with rest pain and tissue necrosis should be planned for intervention to prevent amputation. And also patients with intermittent claudication who are very short distance claudicant, they can be considered if this symptoms are affecting their lifestyle very severe. But otherwise, the intervention indications are if the patient has got a rest pain, because that shows that the patient is going to have some sort of will progress into gangrene and tissue loss. So, non-surgical management, that means lifestyle modification and drugs. So, if you detect dyslipidemia, you start with statin therapy. If there is a hypertension, then you start them generally with ACE inhibitor. Most people, they avoid beta blocker. In diabetes, you need a proper foot care and a good control of sugar. If there is evidence of atherosclerosis, then give them aspirin, clopidogrel, and smoking has to be stopped very sincerely. Other drugs, they may be useful in these cases are rivaroxaban. So rivaroxaban, here it is written 25 milligrams, but that's wrong. It's 2.5 milligrams PD, not OD, it's PD. So rivaroxaban comes into many brand names and generic also. And now it has become very cheap. At one time it used to be more than 100 rupees per tablet. But now I think it is 2.5 rupees per tablet. So rivaroxaban 2.5 milligrams twice a day is the right dose, not 25 milligram OD. 25 milligram OD is very high dose. Low molecular weight heparin in acute ischemic cases are used for in those cases where intervention is planned and you are waiting for things to work out. During that time, you generally that time we give high molecular unfractionated heparin. Low molecular weight heparin is given occasionally, it's not very commonly. Atorvastatin, of course, is used for as a statin. Filastazole is used as a vasodilator. Generally, we start with 50 milligram BD, and if there is a some response but not proper response, then increase dose to 100 milligram BD. This one, BE growth factors been used. They are used as a where nothing works and something has to be done, and the patient can afford such expensive therapy. That time those injections of VEGF are used. They are not very common in use. Now, these are various therapies people have used, and um, they may be for a longer term relief, but they have no exactly direct. But the folic acid we give to reduce the homocysteine level. Now, once all conservative and things are done, or if the patient is having severe claudication, rest pain, or tissue necrosis, then some of these patients may be suitable for transluminal angioplasty and stenting. So, as you are aware, angioplasty is inserting a balloon catheter in a deflated condition into the artery and crossing the narrowing and crossing the narrowing with the guide wire, and then the balloon is threaded over it, and then it is kept at the narrowing. The balloon is kept at the narrowing and then inflated, and that area gets stretched out and opened up. So that is called angioplasty. And if you put a stent on top of that, so then you remove the balloon and then mount a stent, and then again put stent at the narrowed area which has been opened up, then it is called stent. So this angioplasty is very successful in dilating the iliac and femoropopliteal segment. Extremely good in iliac, and next is in femoropopliteal segment. And there is one technique of subintimal angioplasty also, when there is a total blockage of the artery, then with the help of guide wire, one can create a dissection into the artery and then push that guide wire up till up or down till it re-enters the lumen where there is no blockage. So the guide wire is crossed completely and dissecting the intima. And on that guide wire, now you put a balloon, a long balloon, depend on the diameter of the vessel. So you do that, and then keep on inflating that balloon intermittently along the path of that occluded segment. And the whole occluded segment opens up because of balloon, so all atherosclerotic material gets stuck to the one side of the body, and that the lumen gets opened up. So this is extremely useful in patients who have these blockages which are complete, because angioplasty cannot work. Normal angioplasty cannot work where there is no lumen, because the guide wire has to go into the lumen and cross that blocked area. But because of subintimal, one produces dissection, and then even if it is completely blocked, this technique can work and open the arteries. And I have seen people opening up to as distal as medial plantar and lateral plantar arteries, and thereby saving even the digits, which normally may not be possible with a normal angioplasty. So there are some complications because the arterial wall can rupture, and that may be thrombosis later on, and some of them they require stent. So This looks like an angioplasty catheter. It's a long balloon, and so with one you um, inflate the catheter for a balloon. These are the in picture A, it is uninflated, and in picture B, there is inflated balloon. So you can see the effect of angioplasty. This is a stent which is mounted on the balloon, and then it will be placed into that stenoid area. This is a diagram of percutaneous transluminal angioplasty. Yeah, only difference is you have to put a guide wire first. On top of that guide wire, the balloon catheter will go, then balloon will be inflated, and then the stent will be placed. Right. Operative procedure for arterial occlusive placement of a bypass. Reserved for severely symptomatic and after failed angioplasty attempt. And types are axillofemoral, axillobifemoral, aortofemoral, aortobifemoral, femorofemoral, and femoropopliteal. Out of these, most common are aortobifemoral and femoropopliteal. Now, this is the picture of the graft. It is a Dacron graft, woven Dacron graft. Normally, nowadays, they are come with albumin coated, so there is no leakage of blood from there. Earlier, we used to get uncoated one, so in which we had to take out some non-heparinized blood before clamping the aorta, and that blood we used to impregnate this graft and let the platelets and fibrin and everything plug the micro holes into this graft, and we were able to use it. So nowadays, most of these grafts they come with albumin coated, so there is no. So this is the picture of aortobifemoral, and that is the picture of femoropopliteal. This is a neglected case of gangrene in which the patient has developed clear cut and it's a dry gangrene, and there is a clear cut demarcation, and the nature is trying to separate it off and do auto amputation because but the bone will not let it go. So a surgeon has to interfere and cut the bone. In diabetes, generally there is a vasculitis and arthritis. So that leads to distal gangrene, mostly digital and toes and all that. And that leads to gangrene with blackening because of deposition of iron. The picture of frostbite, if the limb is exposed to extreme cold, then and the dampness, then the frostbite develops.